followed by especially with specialization and super specializations and super specializations. So I hope the participants have been wonderful faculty who have seen the program and good luck and congratulations again.
Thank you, ma'am. Today's event is being organized to increase awareness among general population regarding trauma and its minimally invasive pain and spine interventions. We have a lot of exciting things in store for you to join the program. For our first session, I would like to invite our chairpersons, Professor Aman Agarwal, sir.
Respected Director, Madam, Professor R.K. Tripathi, sir, Professor Anil Agrawal, sir, Malviya, sir, Dr. MANOHAR, my colleagues and delegates. I really feel privileged to give vote of thanks to this August gathering on this special occasion of CME on chronic low back pain and minimal invasive pain and spine interventions. It's okay, man. It's okay, man. We are really thankful that in spite of my busy schedule, Director Madam came and blessed this officer with her visa. We are also thankful to Dr. Professor R.K. Tripathi, sir. Sir has been our professor here and we have enjoyed moments with him. I thank you, sir. We have most renowned pain physician of our country, Professor Anil Agrawal, sir, and we can say that he is like a father figure in pain in history or even at national level. So we thank you, sir, for taking our time and coming here. We are also thankful to our ex-director and head of the department, Professor Malviya, sir, who has always been very encouraging when it comes to academic activity. Thank you, sir. We have Dr. Viren, who has been in the LOHIA hospital earlier. I thank you, sir, that you took out the time and came to here. We are thankful to Dr. V.S. Modia, sir, for coming and receiving this occasion. One of the very good physician, Dr. Siddhartha, who has come in Mumbai, and to come from that far to our the CME and bless from his knowledge. I thank you, sir. I also thank my ex-colleagues, Dr. Suji, Dr. Sandeep, Dr. Dev, Dr. Rahi, for coming and blessing this occasion. Whenever you come, I start imagining my residency and make me feel younger. So it is really nice that you all have come here. We also have some of the ex-alumni. Amitesh here. Thank you, Amitesh, for coming. He is doing great work in film actor. And also we have our professor, assistant professor from KGMC, who is working on Dr. Manish here. Thank you for coming. We have some of the faculty from our institute, Ajay Singh, Dr. S.S. Tripathi, Dr. Lot of other faculties of our institute, I thank you all. And CME is not successful without the participation of delegates. So I thank all the delegates who have come to learn from this CME. I also thank all of my faculties, departmental faculties who have come to this CME. We are especially thankful to the organizing committee, especially organizing secretary Dr. Shivani Rastogi and organizing chairperson Dr. Anurag Agrawal for organizing this CME on pay, and that actually caused me in our institute, and CME are possible because financial support from company. So we thank the company who has financed it. Thank you all.
Thank you, sir. For our first, thank you, sir. For our first session. For our first session, I would like to invite our chairpersons on the dais, Professor Anil Agarwal sir, Professor Colonel Arjun Tripathi sir, and Professor Deepak Malve sir. Our first speaker is Dr. Shivani Rastogi ma'am. Ma'am is professor in Department of Anesthesiology at Dr. MANOHAR LOHIA Institute of Medical Sciences, Lucknow, working as a physician here. She is also the organizing secretary of today's event. Morning, everyone. On behalf of the Department of Anesthesia and Medicine team, welcome the esteemed delegates to this short and focused CME. Chronic low back pain is becoming a global problem worldwide, and COVID in the COVID had made office work and school from the home, making limited activities. Chronic pain can be due to various reasons as low back pain, osteoarthritis, headache, migraine, and fibromyalgia. But low back pain is the first and the most second reason for the pain. Second reason for the disability, it is a mental health and economic problems. In 90% of cases, it resolves spontaneously without any treatment. But in 10% of patients, it is a big challenge in conventional medical treatment. And beyond 12 weeks or longer, it becomes the chronic low back pain. The prevalence is around 50%. In India, 60% of people suffer from back pain and one or the other time in their lifetime. It affects the quality of life, it causes psychological morbidity, it causes social consequences and socio-economic consequences. The various pains in the back are body, spinal nerves, facets, sacral joint, muscles, and it may be from the referred pain from various systems. But 90% of the cases are due to the nerves, facets, and disc. According to the manufacturer, facet joint pain accounts for 40 to 50% of the pain in elderly population. It is discogenic pain 6%. Second joint pain is about 30 to 15%, while downward pain is about 30%. Unidentified causes of low back pain. Before we look after for the red flags, what is the image of the patient? Red flags will be 15 red flags, duration of the pain, any history of the trauma, or if patient is having any constitutional symptoms like fever, change, sweats, weight loss, and systematic illness, and undetectable, or if patient is having cerebral anesthesia, which is an emergency investigation. So to treat the chronic pain, multimodal treatment. First, diagnosis is very important. We have to diagnose the first correct culprit of the pain. Then we give the conservative management by the drug, physiotherapy, and other exercises. Second comes the higher opioids and the interventions. If the pain is chronic and it's not really, we can go for the spinal cord stimulations or drug delivery systems, but they are very costly. For low back pain, as a joint is accounting for about 40%, which is difficult to diagnose by CT. It is diagnosed by exclusion, and diagnosis is confirmed by diagnostic MIPSIs. Joint found responsible for spinal pain, which is about 45% in low back pain, 67% in neck pain, and 48% in the thoracic pain. RF ablation of the medial branch gives long-term treatment in this patient. Next, the most common cause is psychosis, which causes the lower extremities. There we have the history of the bowel and bladder dysfunctions of the limbs. The positive SLR and contralateral stretch test, positive femoral stretch test is used for diagnosing these patients. The human procedures which we can and we are doing for the diagnostic as well as therapeutic purpose for 75 to 85 short-term memory, and about 50% have long-term memory. The other patients who are not by this and have a significant compression or the loss, they are managed by the positives and the compression. It has many advantages over surgical. It is minimal. We don't and the small hospital and that's one patients generally and it can touch the now no long hospital admission is this is the patient which was treated by the transfer the disc. This patient was managed by PED. I was the first MRI of the patient. Next common cause is anxiety compression. According to modified Dallas muscular scale, it is 5 grades, depending on the level of tear, how much the tear is. The various MIPSIs are interventions which we can do are intradiscal therapies. We can do camera, we can do decision MRI, having done by managed by intradiscal MIPSI, have 90% after 1 month, and repeat MRI shows we have the inner and disappearance of the which is 30% of the this can be also treated by MIPSIs and MIPSIs and RF treatment for long-term treatment. Go back to which is pharmacology or radiotherapy. All those can be stabilized by cementoplasty. Most problems vertebral mass will use radioplasty or vertebroplasty. This is the patient with and shows relief and function then 60% and this is a good without anesthesia and local anesthesia. Which was managed by Benin calculoplasty, which is the balloon continuously and put the cement at the side of continuously. Problem is the complex sympathetic syndromes in which we can provide the sympathetic resolutions, which can be long-term resolutions can reverse the course of the disease. The other most common cause is the myofascial disease, which may cause the trigger points in the vessels, by trigger others are done with the neuralgia or trivial mass neuralgia. Higher sophisticated procedures will be for the the higher procedures of the spinal cord spinal cord syndrome patient will have persistent medical therapy and for non-spinal problems, there are some complex spinal cord stimulation, but it is very costly. So, reserve for the particular type of patient we can afford and lifelong wellness, lifespan for more than 1 year. This is our OT setup, which could the and the set for the other, with articles to be installed and ERP generated. This is our started with first batch in Swami. First institute in the country has full particular spine and endoscopy set. Most advanced INF is to be installed soon. This is the journey we started in about 2013. Now, after 10 years, with support of the Tamil police, our work has increased to 5 which shows the patient 2015 and 2013. Thank you and welcome to this meeting.
Thank you, ma'am, for sharing your valuable insights with us and focusing all of us to back pain from a pain physician's perspective. Moving to our next speaker, Dr. Manish Singh, sir. Sir is Associate Professor, Department of Anesthesiology, your interest in pain medicine. Thank you.
Giving a short lecture on face. I will be discussing all these under these very points. Treatment of facet joint and role of radiofrequency lesioning. So coming to the prevalence of facet joint as a cause of low back ache, it is around 15 to 40%. And if we see the prevalence of low backache because of the disc disease, it is about 10%. So if you see that higher limit is nearly same for both the entities, so it can be assumed that facet joint orthopathy or facet joint pain is the leading or common cause of low backache. Coming to the anatomy of facet joint, it's a joint between the inferior articular process of superior vertebra with the superior articular process of the inferior vertebra, and it is generally flat or curved. Concave surface of the superior vertebra fix the inferior articular process. So facet joint is aligned laterally to the sagittal plane and it varies in angle. If you see, if you go from L1 to L5 or S1, initially it is more toward the sagittal. Pointer nahi hai kya? It is more towards the sagittal. You can see it is more sagittally placed, and when we go downward, it is more coronally placed. So this joint is more coronally placed, and above joint is more sagittally. This is important when you do interventions over the SI joint, facet joint. Facet joint have capsule which lies posteriorly, inferiorly, and superiorly, but anteriorly it is replaced by ligament of Neville on the anterior side. And here you can see the synovial lining in the facet joint. So it is a synovial joint. Coming to the nerve supply, which is our target in interventions over the facet joint pain, it is supplied by the medial branches of dorsal rami of L5S1. Each medial branch supplies joint above and below. So each facet joint is supplied by two nerves. So we have to block two nerves in order to relieve the pain of the facet joint. So nerve supply to a joint is segment higher. So if facet joint of L3-4 is involved, then so we have to block the medial branches of dorsal rami of L2 and L3. So coming to the course of this median branch, so L5 dorsal rami exit from the intervertebral foramen. So it exits from the intervertebral foramen. So in the fluoroscopy, we can see this is intervertebral foramen. It exits from the intervertebral foramen. It pierces the intertransverse ligament and travels to the neck of superior articular process. This is superior articular process. It transfers to the superior articular process, and it passes under the mammillary accessory ligament. This is a transverse process. This is superior articular process. This is mammillary accessory ligament. It passes under the mammillary accessory ligaments, and then medially it gives the articular branches. Two articular branches, ascending and descending. So here we can see that this is a spinal nerve divided into ventral and dorsal rami. Dorsal rami gives three branches: lateral, intermediate, and medial. Medial at the neck of superior articular process, at the neck of superior articular and inferior articular branch, which supplies the facet joint. So coming to the movement over the facet joint, because concavity is from the superior articular process, articular surface, so movement is restricted by the concavity of the superior articular process, articular surface, because it is facing medially and posteriorly, so it limits the movement over the lateral side and out the flexion. This is very important, the motion associated with largest intravertebral vertebral angulation and strain for lumbar facet joint. You can see facet joint level L1 to L5S1. There is movement which is associated with maximum intervertebral articulation. That maximum movement is possible. These movements are maximally possible. But where the largest strain in these movements, if you can see in L2-3, this is maximally possible, but straining is the patient feel pain or the right bending. So it is important to really diagnose the patient with that if a L2 is involved and it is pain or the right bending area, then it supports the diagnosis that patient of L2-3 is involved clinically. So zygoepiphyseal joint, which is also another name of facet joint, it is common in elderly. It is commonly associated with osteoarthritis, not always. Associated with trauma over the spine and spinal region or the back. It can be associated with degenerative disc disease and previously spine surgeries which had already targeted those facets, lamina or pedicles. So if a young patient come to us with axial pain, more likely he will be suffering, he or she will be suffering from this disease. And if an old patient come to us with low back ache, he will be more of the low back ache. This is a three-joint complex concept. So in a spinal movement, there are three joints. First is intervertebral disc and two lateral these facet joints. So any movement which occurs at spinal level will involve these three joints. So any stress over any of the joint will involve other two joints. So here we can see the flexion is there. There is opening of the facet joint. If extension, there is closing of the facet joint. So any changes or any stress occurring on over any of the joint will involve another joint. However, there is weak correlation between this theory. There is conflicting studies and conflicting results. The present data suggests that facet joint pain and disc pain occur together in only 8% of the patient. If patient has this disease, he does not have facet joint pain. Disc pain, and there are also studies which say this related pain and facet joint pain seems to be discrete entities. They can occur alone. However, there are two studies which say degenerative disease generally facet arthritis. So coming to the clinical signs of this disease, difficult to diagnose clinically. Facet mediated pain is typically non-radicular. This pain is often described with the patient as worse in the morning, upon awakening, and during the periods of inactivity because of the muscle spasm. It may also worsen with spine extension, facet joint palpation, rotatory trunk motion because all the movements are occurring over the facet joint. The pain can be elicited by facet joint palpation or axial loading. However, clinical signs and symptoms have not shown to be specific and sensitive. So, the presence of paraspinal muscle tenderness on palpation is probably the only sign which is weakly indicative of hysterogenic pain. तो लास्ट मैंने जितने डिस्कस किए इसमें से अगर हम ये देखते हैं तो पैरास्पाइनल मसल टेंडरनेस है ये वीकली इंडिकेटिव है कि फेसेट जॉइंट पेशेंट को पेन होगा. It is difficult to diagnose. क्यों? Because here you can see the different pattern of facet joint pain. अगर हम किसी पेशेंट को देखते हैं L2-3 उसका इन्वॉल्व है, L2-3 facet joint इन्वॉल्व है. You can see various areas. Upper area is lumbar L1 to L5. Second is L2 to S1. Third is L3 to S1, and fourth is L2 S1. If L2 is involved, patient can have pain over here, over here, over here, over here. So you have 4 patients, and they have different symptomatology. So that's why it is difficult to diagnose clinically. So what if you can diagnose with these radiographs or CT MRI? Findings common both in symptomatic and asymptomatic. So here no relief. No dependable correlation between imaging studies, including CT, MRI, and facet joint pain. So what we have been told that literature does not support the routine use of radiological imaging as a means of diagnosing facet joint pain. Many studies also conflict two different concepts, that facet joint arthropathy, which may or may not be painful. There are changes in facet joint, but it is not painful. And there is facet joint pain, but there is no arthropathy seen in the joint. Therefore, routine use of these CT, MRIs, and X-rays are not advocated. Neurodiagnostic modality has been tried. CT with MRI using pressure techniques. Initially, some studies have shown positive correlation, but a new study in 2019, the layman have shown poor concordance between facet joint pain changes, signal changes, and facet joint pain. So again, there is a dilemma. सो करें क्या करें, व्हाट टू डू, ये तो डायग्नोज ही नहीं कर पा रहे। अच्छा, so Delphi study from expert panel identified 12 indicators to diagnose lumbar joint pain. They are tried actually. So those that reach the highest uh, highest level of consensus were positive median branch block, and majority of the pressure has been consensus has been done given on positive median branch block, because median branch block is applied as a sole criteria for diagnosing facet joint pain. Other causes such as localized unilateral back pain, spinal muscle tenderness, absence of radicular features, there is no radiation, pain is by flexion, pain if referred located above knee. These criteria has been taken from a study. So, despite poor correlation between historical, radiological, physical examination, zygoepiphyseal pain has led to widespread acceptance of diagnostic blocks. So, diagnostic blocks are mainstay of the diagnostic tool actually. So, confirm that facet joint is a primary pain generator. Coming to the treatment of facet joint, it start with conservative. We have regenerative therapy, physiotherapy, chiropractic, minimally invasive pain and spine interventions, and surgery. So, international facet joint guidelines recommend that at least 3 months of conservative care before proceeding for any procedural intervention in facet joint pain. However, a multimodal approach for the treatment of facetogenic pain is essential. Among regenerative treatments, platelet-rich plasma is the base, have demonstrated benefit in intra-articular PRP. Large randomized control trial is still lacking. There is new modality known as mesenchymal signaling cell. It is in the actually laboratory stage. Coming to the diagnostic block, अब diagnostic block से कैसे हम judge करेंगे? There are multiple guidelines which have endorsed lumbar medial branch block but not intra-articular injections. We have to diagnose by blocking medial branch block rather than intra-articular injections. पहले हम लोग करते थे intra-articular देखते थे, वही मिलता था, हम लोग proceed करते थे. But अभी guidelines कह रही है कि we have to block the median branch. ठीक है? It is based on face validity, target specificity, and construct validity as a selection for tool for median branch neurotomy. Neurotomy करने के पहले we have to do median branch block. Given the lack of evidence of intra-articular injections as a superior diagnostic tool and technical ease of performing, it is easy to perform median branch block rather than giving intra-articular facet joint injection, because capsule is to reach the inside of the capsule is difficult. MBB is recommended as prognostic tool of choice for subsequent medial branch denervation. So, how many blocks has to be performed before a radio frequency denervation? These facet guideline committee have advocated that a single block is advocated. However, these guidelines also advocate a personalized approach. आप 2 बार भी block लगा के patient को neurotomy के लिए ले जा सकते हो, but single block is advocated. So, regarding coming to the intervention, only validated treatment is radiofrequency neurotomy of medial branch nerve. Here you can see the medial branch coming from the at the junction of supraarticular process and transverse. Here you can see superiorly it is coming over the supraarticular process. So before any neurotomy we do neurostimulation. So whether sensory stimulation to be done or motor to be done. So there is a 2020, these guidelines have provided grade C recommendation for sensory stimulation and grade B recommendation for motor stimulation. So it has divided an alternative or to sensory stimulation is to elicit multifidus or other paraspinal muscle contraction. You don't sensory, if you just elicit multifidus or paraspinal muscle contractions, you can proceed to neurotomy. Now this is a technical actually mantra for those who are performing neurotomy is that these practitioners should ideally insert the cannula at a sharp cephalad medial angle, so they are situated parallel to medial branches. You have to place your cannula parallel to the nerve so as to generate the max viral lesions rather than pointing across the nerve. So efficacy of radio frequency denervation, it has been shown that lumbar facet RF denervation provides sustained relief in 50 to 80% of the patient without previous back surgery. However, it reduces to 30 to 50% in patient having low back surgery for the low back ache. A meta-analysis in 2014 shows that RFA of lumbar facet joint was more effective than placebo and steroid injection over the joint. In 2017, another meta-analysis shows significant reduction of low back pain originating from facet joint over the 12 months in cases treated with radio frequency ablation of median branch. Manchikanti has performed several actually systematic reviews, and he says the review says that there is moderate evidence supporting radio frequency neurotomy of the chronic facet median branch for chronic low back ache. So when can be if a patient has been treated with RF ablation, so we can repeat or not? Yes, if a patient who has obtained at least 3 months of relief, meaningful relief after the neurotomy, it can be done twice per year in that patient without repeating prognostic block. You don't have to repeat prognostic block if same level is involved. This is another modality. It is high intensity focused ultrasound ablation. This is an alternative approach to RSA. Here, HIFO is a novel non-invasive technique whose target point is entire facet. It uses ultrasonic waves whereby nerve endings terminate to innervate the joint. Its advantage is non-invasive nature and it does not entail radiation exposure. Other forms of denervation we used are laser, cryoablation, phenol, alcohol injection. Some have lack of precision, some can have side effects such as interfering with the foramen contents. Serious complications are uncommon with facet interventions. I am basically focusing on RF ablation, uncommon. The most common is neuritis in less than 10% of the patient. Numbness and dysesthesia can be there, but as you know, it's transient and cell-limiting. Burns are rare with RFA. To summarize, facet joints are common cause of low back pain in elderly. Diagnosis is often difficult. Diagnostic blocks are better tool to guide to treatment. Radiofrequency denervation of median branch block is the treatment. It is safe, daycare can be repeated, and newer modalities of treatment needs more validation. Thank you. Any questions? सर अभी स्टडीज में सर्च कर रहा था कि इतनी स्टडीज है नहीं सर उसकी. सो अभी मतलब केस सीरीज वगैरह लोगों ने निकाले, बट अभी रैंडमाइज आरसीटीज वगैरह नहीं आए हैं सर. अभी सर मैंने जज नहीं किया इसको, मतलब मैंने देखा नहीं इसको कितना है. अच्छा है सर. हाँ, थैंक यू सर.
Thank you, sir, for your inspiring words, and we hope that you will continue to share your knowledge and experience with us in the future. Our next speaker is Dr. Rakhi Gupta, ma'am. Ma'am is Associate Professor in Department of Anesthesia and Pain at HIMSS Barabanki and Visiting Consultant Pain Physician at Vivekananda Awadh and Chandan Hospital.
कौन सी मैम पे कौन सा
Thank you for the kind introduction. Okay. Thank you to the organizing committee, Dr. Anurag sir, Shivani ma'am, and the whole of the RME team for this opportunity to present here. I'll be talking about a very simple looking but very complex joint of the body and the complex pain syndrome, which is a difficult to treat entity once it becomes chronic. So it is sacroiliac joint syndrome and the MIPSIs associated with it. Starting with the anatomy of the joint, the sacroiliac joint is a diarthroidal joint. It is the largest axial joint of the body, and it is a diarthroidal joint composed of synovial membrane and a fibrous capsule. It is auricular in shape, and only anterior two-thirds of the interface between the sacrum and the alveoli is the true synovial joint. The posterior one-third is the interosseous ligament portion of the sacroiliac joint and is fibrous. The articular cartilage is hyaline on the sacral side, and it is fiber cartilage on the iliac side. The sacral side cartilage is thicker than the iliac side, so arthropathy occurs more, starts from the iliac side more than the sacral side. The cartilage is rough, coarse, irregular, according to the undulations of the joint, an irregular joint. In most of the joints of the body, the stability is at the cost of mobility. So the mobility is there and stability is less, like in the shoulder or hip joint. But this is a joint which is very stable at the cost of mobility. So there is very less mobility at this joint, but it is very stable. For stability of the joint, lots of ligaments are there which are reinforcing the joint. Posteriorly, we can see the iliolumbar ligament to start with, the interosseous ligament, the posterior sacroiliac ligament, sacrotuberous ligament, and the ischial sacrospinous ligament. Anteriorly, what we can see is the ALL, the iliolumbar ligament, the anterior sacroiliac ligament, the sacrospinous ligament, and certain ligaments which are connecting the sacrum to the coccyx area. The coccyx area, a lot of ligaments are connected, anterior, posterior, from the lateral side also. So in total, the sacroiliac joint is encompassed by all these ligaments. So these ligaments basically restrict the motion of the sacroiliac joint in various planes. Like the forward flexion of the joint is restricted by the posterior ligaments. The backward extension is restricted by the anterior ligaments. The lateral bending is restricted by the iliolumbar ligaments. And the rotation of the side joint is restricted by the interosseous ligaments. So the availability of these ligaments is paramount for the stability of the joint. Coming on to the muscular support of the sacroiliac joint, a lot of muscle support, enumerating a few: rectus spinal, multifidus, gluteus maximus, piriformis, biceps femoris, the deep, the core muscles of the body, that is the transversus abdominis, and the iliacus and pelvic floor. To complete the list, there is the posterior latissimus dorsi complex, which attaches to this area by a thoracolumbar fascia, also becomes a corset which supports the sacroiliac joint. Coming on to the nerve supply of the sacroiliac joint, anteriorly the ventral surface is supplied by the L4 to S2 branches from the sacral plexus. And dorsal surface is supplied by the L5 dorsal rudiment and the dorsal ramus, and S1 to S3 lateral branches. Some communication can also occur from the L4 and S4 branches. Coming on to the biomechanics of the sacroiliac joint, it is a joint with less mobility, but mobility occurs in all planes. Mobility is at this point, the rotation occurs. At this point, two types of movements occur. These are nutation and counter nutation. Nutation movement is this when the sacrum is going forward and the coccyx is going backward. Counter nutation is when the sacrum is going backwards and the coccyx is going forward. The work of a sacroiliac joint is for stability and transmission of weight. So the axial spine, the weight is transmitted through the sacroiliac joints equally towards the lower extremity and vice versa, from the lower extremity towards the axial spine. The prevalence of chronic sacroiliac joint pain is 15 to 30% in patients reporting for chronic low back pain. The causes of intra-articular and extra-articular side joint pains are: intra-articular are arthritis, degenerative or spondyloarthropathy, malignancies, trauma and infection. Extra-articular are ligamentous injury, bone fractures, malignancies, myofascial pain, enthesopathy, trauma and pregnancy. The red flags such as malignancy, trauma, infection can be ruled out by history, can be ruled out by investigations like CRP, TLC, and the choice of investigation will be an MRI, which will diagnose these conditions. Coming on to spondyloarthropathy, it is a condition present usually before the age of 45 years. Insidious onset, inflammatory type back pain is seen The patient is good with mobility and there is stiffness with restriction of motion. There is early morning stiffness, and this is a typical inflammatory back pain history. And the imaging will be diagnostic of edema at the sacroiliac joint, which will diagnose the spondyloarthropathy. It has a various classification: ankylosing spondylitis, psoriatic, reactive, and it is inflammatory bowel disease associated arthritis. So mostly the pharmacotherapy is there for the spondyloarthropathy, and for pain physician we have to diagnose it and subject the patient to NSAIDs, and for further treatment will be taken by the hematologist in the form of a TNF alpha inhibitors. Spondyloarthropathy can also mimic certain conditions which we need to diagnose. Among them, the prominent among them are osteitis conversins ili. This condition is present when there is sclerosis seen on the ilium side of the joint, on ilium side of the joint, but the joint is per se very much normal. It is usually seen as a result of strain because of the weight of usually pregnant women. Often presents after pregnancy, associated sclerosis, and no erosion of joint space narrowing seen. It can be as an incidental finding, or it can be associated in very less amount of cases with pain. Another condition is diffuse idiopathic skeletal hyperostosis. The patient will present you with inflammatory kind of back pain, especially in the thoracic area, and you'll think that this is a inflammatory back pain. But the sacroiliac joints are normal. The associated comorbidities are diabetes and obesity, in which these patients present. Pregnancy is a physiological condition because of increased weight, exaggerated diabetic posture, mechanical trauma, partition and harmony, induced ligament laxity predisposes parturients to sprain of the SI joint ligaments, which results in pain. If the patient is having a discrepancy between true and apparent length of the ligament, then the patient will have SI joint dynamics changed, and they can have this pain. Another condition, very common, lumbar sacral fusion, which eliminates all the adaptation capabilities at the infrabismal junction, thereby transferring the stresses to the SI joint. If the instrumentation has not maintained the lumbar posture of the spine, then again, the sacroiliac joint dysfunction will happen in these patients. So after ruling out all the red flags, spondyloarthropathy, and other mechanisms of injury, the main person who comes to a pain OPD is an SI joint dysfunction patient. So what are the micro and macro traumas which result in an SI joint dysfunction? They are a combination of axial loading and abrupt rotation. This can happen when you have a direct fall in the buttocks, or a motor vehicle accident in which the backside has been hit, and an unanticipated step into a hole from a miscalculated height. Pathological changes which can happen, which can lead to nociception, are capsular synovial disruption, ligamentous tension, hypermobility or hypermobility, shearing forces, joint mechanics alteration, micro-macro fractures, soft tissue injury, and inflammation. In continuing with the SI joint dysfunction, I want to emphasize that the pelvis is a kinetic chain in toto. That is the axial spine, the SI joint, the iliac crest, and the pubis symphysis, and the associated muscles and the ligaments. They all are a combination. They work in a kinetic chain. So eventually, for example, as the hip adductor muscles are connected to the upper and lower rams of the pubis, the forces of these muscles are transmitted to the pelvis and eventually to the SIJ. So in the patient of SIJ dysfunction syndrome, you should also look for these muscles and the pelvis in toto for the whole management, else you will fail. So there are various other case reports which showed sacroiliac joint dysfunction in a different manner. So a very vivid presentation of SI joint can occur. Like non-traumatic testicular pain due to SI joint dysfunction. And this patient had pudendal neuralgia because of pudendal nerve compression between the sacrospinous and sacrotuberous ligament. And this was treated with manual therapy and hip mobility and SI joint alignment. This patient usually stress-related reactions occur in the lower lumbar spine in the form of pars interradicularis defect. But in this patient, it was also seen that stress-related reaction was occurring in the SI joint. How it was diagnosed? Even though investigation could diagnose it, only a bone scan could diagnose it. Another case is, they have emphasized in this paper that whenever a patient of SI joint degeneration is occurring to us, then we should also look for concomitant lumbar disc herniation, because SI joint dysfunction is much more prominent in the patient of lumbar disc herniation. Both should be treated simultaneously to get better results. This is a very interesting paper in which we have seen that this patient had like diffuse kind of disc of L5S1, and the physician must not have done the whole workup. So, and of course, there was neurological, sensory motor, and sensory symptoms and paresthesia in the lower extremity. So, we thought it was a radicalopathy. We went for the fixation of the L5S1 lever. That exacerbated the SI joint pain, which was the primary cause. So, everything was explainable, but not the symptoms. So, it was told that in this kind of patients, later on it was diagnosed as an SI joint syndrome, and the lumbar surgery was like it had not to be done. So they explained that the SI joint anterior capsule can be ruptured, and the inflammatory mediators can irritate the lumbosacral plexus present there. They can cause this kind of symptoms in the lower extremity. So we went and do all the examination of the SI joint before embarking upon any kind of surgery. Another case report, and hypothyroidism was present, and again the imaging showed the right results. How to diagnose it? Mechanical lesion associated with trauma can be there, as well as adjacent lumbar arthropathy or fusion can be there. That is the history portion. The patient will usually present with axial back pain on like stepping or like forcing the leg on one leg. Supposing the patient is standing on one leg, pressurizing it, and that can happen, the pain can occur. It can occur in hopping activities and standing activities. The typical axial loading and flexion activities inducing sacroiliac joint pain is not present in a sacroiliac joint dysfunction patient. You have to open the whole mind before diagnosing these conditions. So symptoms can be related to joint hypermobility or fixed subluxation. So the site I have explained is below the L5 area. Mostly 95% of the patient will have buttock pain. 74% will have lower lumbar pain. The lower limb 20%. That is the pattern. So these are the provocative variables. They said that the height force test has the maximum sensitivity, and it is a detailed slide, so I'll be escaping it because of lack of time. So they say that maybe 3 out of 6 tests, if they are present positive, then that is indicative of a positive predictive ratio of 60% for a diagnostic positive block. So these are the tests. To complete the workup, if you don't have a spondylorthropathy or other red flags, sacroiliac imaging is not of much role. So just to complete, you have to see for the oblique and lateral radiograph of the SI joint, CT for bony lesions, MRI for soft tissue inflammatory lesions in degenerative. A bone scan can be used as in one of the papers. And you have to look for other adjacent lumbar spine and MRI of the hip to rule out other causes. So the diagnosis is by history, referral pattern, provocative test, more than 3, but the gold standard is a diagnostic block of the SI joint. Again, 20% false positive also occur with this technique. Management is one of the most challenging problems confronting a pain physician. We have to correct the underlying pathology and alleviate the symptoms. And because the joint is at such a place that it is used in every activity of the life. So it is associated with a lot of distress for chronic low back pain patient. So a lot of psychosocial issues are there. As in any chronic pain condition, you have to deal with them also. In conservative management, if the patient is having negative discrepancy, use of show inserts is there. SI joint pain resulting from altered gait mechanics and spinal malalignment, physical therapy will work, osteopathic manipulation will work. Non-surgical stabilization, like a bit, can be used for pregnant patients who have ligament laxity. Core and back stretching and strengthening exercises are the core of managing the SI joint dysfunction syndrome. So these are the core muscles which need to be strengthened, and these are the rehabilitation exercises for the SI joint pain. If you want to follow an interventional approach for the SI joint, then this algorithm can be followed. Here, if the diagnosis of SI joint is by history, examination, and imaging, a diagnostic SI joint injection is given. If more than 70% pain relief is there, then a 4 weeks course of physiotherapy and NSAIDs is given. Continued pain is then the therapeutic SI joint injection is given. If the therapeutic SI joint injection has more than 3 months relief, then you repeat it. If less than 3 months, then you go for either a minimally invasive SI joint fusion or a SI joint RFA. Neuromodulation is another area where things are coming up. So how do you perform a SI joint intra-articular injection? So the patient, after the proper investigations and workup, is planned for the minimally invasive procedure, placed with the pillow under the abdomen to decrease the lumbar lordosis. And then in the AP view, the medial line will, two lines will be seen. Medial line is the posterior joint shadow, and lateral is the anterior joint shadow. We have to place a needle in the posterior joint. So in the lower portion of the posterior joint, so we do an contralateral oblique to superimpose these joint lines, and then the lowermost portion we insert a needle. What I have seen in the practice is that once you put a dye and it is not inside the joint, you are at a loss, because then you cannot find the joint again. So what I've started doing in difficult cases is that I have started putting two needles from the starting. If one needle will not show the dye spread, the other needle has likelihood of showing the dye spread. So your procedure is not a failure then. So the SI joint, I have not put the lateral picture. Shivani ma'am showed a very good lateral picture of the SI joint, in which the whole of the line of the anterior and the posterior capsule was having the dye spread. So that is important. And you have to look at the lateral image for seeing the loss of extravasation. Otherwise, your diagnostic test will be fallacious, wrong, false positive. So again, you insert the needle in from contralateral side towards the joint, and you give your dye, and then you give your therapeutic agent like 0.5 ml of dye goes, and 1 ml of local anesthetic plus 1 ml of steroid goes. Now, as with all degenerative procedures, the degenerative and dysfunctional areas, PRP works well. So this was also shown in these two studies, in which PRP has better role at 3 months in comparison to a corticosteroid for these kind of patients. Ultrasonographic injection of SI joint is a OPD decay procedure, which you can do just in the OPD, also superficial joint, not much of tension. You can just place your curvilinear probe here, go towards the sacral ala, and you can see a gap between these two areas. In my personal practice, I have used it for patients who cannot come, like, and a lot of pain cannot be posted to the OT on the that or the other day. And in a pregnant patient, I have done a patient who had history of sacroiliitis before pregnancy, but because now she's pregnant, she cannot take NSAIDs and paracetamol is not relieving. So I did an ultrasound guided injection, and she was like 100% relieved for this pain. So these are the clinical reports, how you can go about it. Coming on to radiofrequency ablation of the sacroiliac joint. Nerve ablation of this joint can be done posteriorly only. Okay, so L4-5 dorsal ramus has to be ablated, and the lateral branches of the S1, 2, 3 lateral branches have to be ablated. There can be three approaches. Many approaches are given in literature, but three are important. Like monopolar lesions around the S1, S2, and S3 foramen, and monopolar lesion at the L5 dorsal ramus, or a strip lesion of these lateral branches, or a leapfrog technique, like one lesion is made here, then it is jumped over, this lesion is made, again jumped over. This type of deletioning of the denervation of the joint per se can occur. And these are the three techniques. So for better diagnostic accuracy, as an SI joint injection will also anesthetize the anterior portion and the posterior portion, then of course the relief with the cold or an other procedure will not be so much as compared to an intra-articular injection. So better diagnostic value, if anybody wants, lateral branches can be anesthetized individually, so to see for it, to see for the diagnostic accuracy of a RFA. So cool RFA procedure is done in this manner. Dorsal ramus is the target first, and then the three targets are the S1, S2, and S3 level. So this is the lesion size of a cold RFA in comparison to a conventional RFA. The lateral branches have there's a very varied anatomy of them. So it is imperative that you put a bigger lesion so that it will be contained inside the lesion. Again, pillow below the abdomen to reduce the lumbar lordosis, dispersive plate to the posterior thigh, sterile drapes, IV sedation, and optional bowel preparation can be done. So these are the placement of the needles. First of all, you have to place 3 needles in the S1, S2, S3 posterior lateral surface of the foramen, and to designate them as initial points. Then an epsilon marker is placed on your needles, the epsilon marker is placed in the center, and this distance is around 0.8 to 1 centimeter from the needle insertion, so that there is a good enough distance between your lesion and the S1 root or the S2 or S3, and that will not be ablated. So after this, the inserting, this is the system, this is the distilled water system for cooling the probe, and this is the probe which is utilized for lesioning. So after the insertion of the introducer cannula, you place it on the bone at various o'clock positions as shown. For S1, you have to use on the right side 2:30, 4 o'clock and 5:30 lesioning, and similarly has to be repeated on S2 and S3 side for these areas. S3, 2:30 and 4 o'clock lesions are sufficing. So after this, the stillet is withdrawn, and then your inserting RF cannula is inserted, which is around 2 millimeter above the pelvic bone for the lesion to take place. So this is the manner in which I have placed these electrodes, and this is the manner in which literally you can see them. So you can see there is a gap between the pelvic bone and the electrode. So L5 is also done. So it has been seen that repeat cold RFA after the effect of SI joint RFA goes off has worked well. But another study came in 2018 which questioned the RF efficacy of a sacroiliac joint because of the lateral branch anatomy is very variable. So the better results were there with lumbar RFA, like median branches in cervical and the lumbar area, rather than in the SI area. So they did a cadaveric study and saw that the lateral branches are not in that anatomy which was originally thought. So they changed the o'clock positions of the lesions, and they said that this is a better area. If you have received like not very good result, you can go for these areas instead of the original one. Another is a simplicity probe, the long strip lesion which I explained. You can insert this probe at beside the S4 foramen, and till the sacroiliac you keep on inserting. Initially, local anesthetic is given by a 25 gauge spanning needle. 3 monopolar and 2 bipolar lesions are created by the simplicity probe. They have seen in literature that the comparison of simplicity and cold is better. Another was RF lesioning of the SI joint, in which the SI joint was ablated in a leapfrog fashion. The needles were placed like this, and lesioning were made one after another. They said that there was relief for 12 months. For any of such patients, complications can occur in the form of hematoma formation, neural damage, trauma to the sciatic nerve, weakness secondary to extra-articular extravasation, temporary worsening of the pain due to temporary neuritis. Yeah, for neuritis, whenever you ablate, before that you have to give local anesthetic, a small amount of steroid. So I have done few cases and I have not found any of these complications. Neurostimulation is another area where peripheral nerve stimulation has been done, and electrodes have been placed. Good results have been there in chronic sacroiliac pain, and final implantation has been done subcutaneously. If nothing is working, refer the patient. Sacral joint arthrodesis is done by, it is a minimally invasive procedure, CT scan guided also, and an open procedure also. Coming on to summarize my presentation and my experience. Always use less volume. I would advocate that you should use less volume, especially in diagnostic blocks, as it may lead to false positive, especially due to extravasation. Symptoms can be very variable. It is not a very bookish picture. Psychological counseling is of paramount importance. Degenerative SI joint, not an easy joint to treat. I'm treating a patient for the last 3 years. Every 6 months, I give her SI joint injection for a relief of 6 months for the last 2 years. Then I did a cold RFA of the joint, and it also lasted only 6 months. So it's again sports injury. Look at the pelvis in total. So I'd like to like anybody can ask me any questions, and I would also like to ask all the pain physicians of their experience of the cold RFA. Thank you. Do we have time? एक छोटा सा वीडियो था, दिखा सकते हैं? टाइम है? इसी में ये बस cold RFA का सेटअप है, कैसे करा जाता है. This is distilled water. This is the machine at 60 degrees for 150 seconds. आपका ये ablation process है. This is the cannula. This is going inside the patient. The spinal needles on the three S1, S2, S3, and the corresponding needles adjacently to it. As the fluoro picture. Okay. Thank you. Any questions? Thank you, sir. So PRP का अब किया है, अभी रिजल्ट अभी देखना है, 1 महीना हुआ है, जो मैंने लिटरेचर पढ़ा है वही 6 weeks to 2 months में उसका पीक रोल आता है, तो प्लान यही है अगर अच्छा रहता है तो 6 weeks पर रिपीट करेंगे, सिंगल डाल के नहीं छोड़ेंगे अभी, प्लान यही है।
वीडियोस है,
थैंक यू।
ऐसे नहीं कि प्रेजेंटेशन के वीडियो है।
Thank you, ma'am, for your insightful talk. We are truly grateful for the time you took to speak with us today. Our next speaker is Dr. Amitesh Pathak, sir. Sir is Assistant Professor, Integral Medical College, Lucknow, and Director, CME Hospital, Lucknow. Sir. Yes.
Thank you so much, Dr. Anurag sir and Dr. Shivani ma'am. Thank you so much for inviting me and giving me this topic, because this is one of the reason I'm in pain. One of the reason is this procedure, what we do. I love this procedure, and high regards to Professor Anil Agarwal sir and Professor Kannan Tripathi sir. You are like father figure to me, and I always seek your blessings, because you stand and the scene changes. And I would like to thank Dr. Deepak also for coming here. Also. So it's nostalgic to be in RML, because I've been here for 3 years. I've been an SR here, and Professor Malvi sir allowed me to do 3 days of pain clinic while being an SR also. So that was big for me, because I learned PDCC from BHU, where I learned about pain medicine, but I got confidence from RML, so that I could do my practices in private setup, in the corporate setup, and presently I'm in a medical college. So today's topic is, my topic is percutaneous vertebral augmentation for low back pain. So I would start with a case study. This is an 87-year-old male, and he had a history of fall in washroom. So this person, he fell in the bathroom. He had a very severe back pain, and he was unable to sit. He was unable to walk, and there was no bladder and bowel involvement. And everything was tried. 3 weeks of conservative treatment was given, bisphosphonate or NSAIDs, rest, everything was tried. So if you can make out from the MRI picture, the diagnosis, the people sitting in the front might be knowing it, but the people sitting in the back, the diagnosis is जो पीछे बैठे हैं residents, sir, is compression fracture of L2 vertebra. Reason was osteoporosis. So it was managed by percutaneous kyphoplasty, and this is how we do it. So coming to introduction, how it is a minimally invasive pain and spine intervention like kyphoplasty and vertebroplasty, in which bone cement, that is polymethyl methacrylate, is injected into a fractured vertebral body to relieve pain. So what is the purpose of doing it? You want to fix the fractured bone in the vertebra, and for the treatment of the painful pathological vertebra. That's the reason behind we do this. So what is the objective of this vertebroplasty or kyphoplasty? One is foremost is pain relief, then to give stability to the vertebra, increase the height. If it is a collapsed vertebra, we do kyphoplasty. Whenever this kind of a patient comes to you, they already have so much of pain that they bend forward and they have a stooping gait, and sometimes they have a kyphosis. So you want to correct that, and further you want to prevent the collapse. So indication is painful vertebra is osteoporotic fracture. There can be neoplastic fractures in multiple myeloma. Tumor infiltration, sometimes hemangioma can also present with this. And we do vertebroplasty or kyphoplasty in this. So what is the exact mechanism of pain relief? It is debatable, but most of the patient, the pain relief is excellent, and many times it is more than a year or so, it's breaking. But I have seen patient who we have done, and it's been their pain relief for more than 5 years. So the acceptable theory is filling of the clefts and stabilization because of cement used in the vertebroplasty. It restores the strength of the vertebral body. And the thermal theory is that the heat generated by the cement, that is polymethyl methacrylate, it causes the damage of the free nerve endings of the vertebral nerves. So that causes the pain relief. So pre-procedural, what do you want? To have an X-ray, then you want to have an MRI, T1, T2 and the state images. This kind of images. Well, if you can make out there is L2 vertebral collapse vertebra. Or in this, you can make out there is at the L1 level and L3 vertebra. If you can make out the difference between the height of the vertebra, L1 is collapsed and L3 is collapsed. This kind of MRI you will often see in the patients having a vertebral compression fracture. There are some absolute contraindications, like burst fracture with the posterior wall restriction. You don't do vertebroplasty in this. Then the pre-existing neurological deficit, you have to refer it to the neurosurgeon. Lack of coherence between the patient's pain and the radiological lesion. We are not treating the MRI or the X-ray. We are treating the patient. Then uncorrectable coagulation disorder. Then if there is a systemic infection or spinal infection, you are not going to do this procedure. These are the absolute contraindication. Then relative contraindication like previous spinal canal stenosis, damaged pedicle or the articular facet, more than 65% loss of the vertebral body. But sometimes we in that also, Anurag sir is too much expert in this. He does multiple levels. Then if there is a cardiopulmonary status, a difficult lying, patient is difficulty lying prone because we do this procedure while the patient is lying prone. If he's not able to lie prone, so it's difficult for us to do this. Then the previous multiple surgery for obesity may also cause poor visualization of osseous structure under fluoroscopy. You have to see the structure, you have to see the pedicle, then through the pedicle you have to do. So you cannot do a judgment kind of thing like while doing this vertebroplasty, because any injury to the pedicle, you can land up in the spinal canal. So what we need actually in this, majority of the time we do it under local anesthesia, but if anesthesia is required, you can give simple midazolam and fentanyl and the job will be done. These are the few things which we require during vertebroplasty or kyphoplasty. Basic difference between kyphoplasty and vertebroplasty, procedure is same. In the kyphoplasty, what you do, you put a balloon and you increase the height of the vertebra and then you put the cement. In vertebroplasty, you don't put the balloon, you simply put the needle, Jamshedi needle. This is the Jamshedi needle, you put the Jamshedi needle and you infill the cement in that. So what is the end point of your procedure? When you reach the anterior and the middle third junction of the vertebral body, the wall of the venous plexus. In that time, once you are satisfied with your needle position, you prepare your cement, and like the cement should be like paste like of consistency, toothpaste like of consistency, and then you do it. Now, how much is the amount of cement you want to infill to produce the pain relief is still uncertain, but the current recommendation is if you are doing a thoracic level, 2 to 3 ml is enough. If you're doing lumbar level, 3 to 5 ml is enough. Maximum level of injected and is still underdetermined yet. More than 3 levels, you should not do at once. And post-interventional, a CT scan or a chest X-ray must be done to look for the cement leakage and all. This is how we do. The cement has been filled in the vertebra. I have taken this slide from Anurag sir. He has done this, like 4 or 5 levels he has done. So some complication can occur, like minor complication chances are around 5 to 10%, major complication less than 1%. Majority of complication, they are transient and self-limited. Some minor complications like which are asymptomatic, like venous lumbar plexus embolization, small leak in the perivertebral soft tissue, it can happen, nothing to worry. Pulmonary pulmonaritis can occur, and small lung embolism can occur. Usually they are asymptomatic. The major complication which we are worrisome things which we should always think of while doing this vertebroplasty, because it's not an easy thing to do. Vertebroplasty, you have to be precise enough to do a vertebroplasty. Anyone can't do it unless and until he is an expert of it. So leakage of cement in the spinal space, a rare complication requiring immediate or surgical decompression. So you always should have a neurosurgeon in your, standby, or you should inform him that we are going to do this procedure. If some complication, it can happen to anyone. If it happens, you can have his expertise. Spinal cord direct lesion leading to paraplegia can also occur, and a large lung, if you are very unfortunate, when large lung embolism with acute respiratory failure never happened to any one of us. So what happens when we don't intervene in time? So this is an X-ray of 23rd April 2019, and you can see if you can make out this one. And the same patient X-ray done on 30th July 2019, vertebral compression has been increased in 1 or 2 months. Extreme vertebroplasty, L2 vertebra, if you can see that. We did vertebroplasty for this. Something like this. So at 2 level, vertebroplasty is done. Cementoplasty or vertebroplasty is a very gratifying experience. If we as a pain practitioner, we always keep this trigeminal neuralgia, and the vertebroplasty or kyphoplasty is always high in our regards, because a bedridden patient who is coming to you and you do this beautiful procedure and the patient inside the OT, he just sets up. Very gratifying, and you get lots of blessing for this. So she was a bedridden patient more than 6 months, and she was happy after the procedure. Next day itself, half an hour after percutaneous vertebroplasty. Similarly, a CA prostate patient with bone mets who was unresponsive to radiotherapy and some iron therapy. So there was multiple levels of osteoporotic. 3 levels of vertebroplasty were done, and it provided a very good relief. So you should not worry about the level at which you are doing a vertebroplasty. If you are expert enough, no level is a taboo. Technique actually matters. Which level you are going to do this. So this is, I guess, thoracic level. D8 and D11 percutaneous vertebroplasty done with immediate pain relief. So another case was a CA lung case in which multiple level of thoracic level were involved, and D5, D10 and the DL2 vertebroplasty and kyphoplasty was done in this patient, and the patient was completely bedridden. She was the one. Now the patient is sitting and walking after 4 months. Efficacy in osteoporotic compression fracture, 75 to 90% of the patient experience a dramatic and the complete relief of pain within 72 hours of the intervention. In neoplastic compression fracture, around 80% of the patients, they have experienced a reduce in the narcotic requirement. So they feel a very complete pain relief. So efficacy, improvement of complete pain relief, and by Poultry et al., they say that improvement or complete pain relief in 84% of the patient. There was no change in 9% of the patients. None were worse. There are few assumptions which are, I guess, some assumptions only, that contraindicated in moderate to severe retropulsion, then loss of more than 850 to 70% of original vertebral height. There are assumptions. Volume of cement matters, it doesn't matter at all. If it is a lumbar, 3 to 5 ml is more than enough. If it is thoracic, 1 to 2 ml is more than enough. So what is the take-home message? This is a procedure for improved quality of life. If you have a patient like this and you do vertebroplasty or kyphoplasty, if done with the expert's hand, the quality of life of the patient increase, and it does not correct the underlying cause of the vertebral fractures. So you have to take care of that also. Appropriate therapies should be initiated, and it can be combined with other therapies as well. So the important is not the years in your patient's life, but important is what the life you give in those years. So these are a few of my patients who are very well gratified and satisfied that she was, and that lady is an 83 years old and that lady is 78 years old. She was completely bedridden, and in next day she was smiling and taking a snap with me. So I was also feeling blessed. So this is my house, newly started hospital, Sad Hospital. It's in Gomti Nagar, and apart from pain, I'm doing all the interventions here. So if you have a time, sometimes you can visit to this cute hospital. Thank you so much.
Thank you, sir, for your talk. Your words have given us much to reflect on and will certainly inspire our actions. Our next speaker is Dr. Devendra Singh, sir. Sir is working as Senior Consultant Interventional Pain Medicine in Sahara Hospital, Lucknow. His area of interest is percutaneous spine interventions.
First of all, I thanks the organizer, Dr. Anurag sir, and it's my privilege to be here and talk in front of my teachers who have been from Malviya sir from my UG days to Anand sir and R.K. Tripathi sir, who will be always my inspirations for whatever I do in pain medicine. So this is another topic, which is the topic was the name of the topic was given by Dr. Anurag for cutaneous spine endoscopy, the future of spine care. We'll start with the introduction, understanding of the foraminal anatomy and pathophysiology of the back and leg pain, indications, contraindications, advantages, techniques. So, surgical or interventional management of back and leg pain is evolving and changing due to the better understanding of pathoanatomy correlated with its pathophysiology. Ability to isolate and visualize the pain generators in the foramen and treating them serves as the basis of transforaminal endoscopy. Till now, we have seen that through last 3 or 4 decades, back pain, when it was unmanageable, it always lands to a neurosurgeon in the last, starting from orthopedic surgeons to neurophysicians and then to neurosurgeons. There are only limited things. Limited means either you give on medications, physical therapies. If not responded, then straight away to the bed rest. If not responding, then go for surgery. And surgery started from laminectomies in case of canal stenosis with fixations. Otherwise, then microdiscectomies. But the approach to the pain patient was entirely different thing. Here the approach is entirely different. We always, till now, it was always focused to decompress the canal. That's what the concept of laminectomies, laminotomies, and microdiscectomy were there. The entry point for the laminectomies or microdiscectomies was always the lamina. Either there used to be a laminectomy to open up the central canal, or there used to be microdiscectomies where you do make a hole in the lamina and then again into the central canal. But in the future course of time, when more and more studies of chronic back pain and the radicular pain evolved, the pain generators were identified. And one of the most important pain generator was dorsal root ganglia, DRG. It is like if you build a pyramid, DRG is on the top. It is the most sensitive structure in whole spinal canal. It is not the central canal. Central canal structures are not so sensitive as the DRG. DRG is the most sensitive, which starts from the central to the lateral canal. And so the focus of phenomenal endoscopy or other endoscopic procedures is to decompress the DRG. And what is irritating around the DRG or the exiting of the traversing route, we have to clear that area. So you can see the anatomy here. This is the Kendall's triangle, which was the anatomical basis of percutaneous transforaminal endoscopies. Now we are not going through the central canal. We are leaving the central canal because the pathology lies here. So most of that was the reason the patient of failure increased so much, because when the pathology is lying in the lateral canal or subarticular region or in the foramen, and we are decompressing the central canal, where is the point? If you are being pressed, your neck is being pressed like this, and you are removing the wall instead of removing the cause. So now the approach have changed. So now we have identified that either there is a DRG, which is a big defective, whether it is a chemical condition by the or the fragment compression directly to the DRGs or exiting routes or the traversing route. So this is the approach. Basically, the safe triangle, the Kendall's triangle, where the lateral boundaries by exiting route, this is where the facet joint, this is where and superior facet is the another wall. So our scope is the place where the scope is going to lie. This is the analytical cadaverics. You can see the exiting route, and this is the place. This is the superior facet. This is the place where your endoscopic sheath has to be there. See, what are the pathophysiological events? There is initially an annulus. We can see here. This is annulus. This is the annulus. And with the different grades of pain, this is an extruded fragment, which is almost, and this all may last for more than 6 months or years also. This nucleus material, the fragment has been migrated. When it comes to the orbital space, it gets vascularized, organized, and it becomes toughened. When it becomes toughened, then the weakness starts, because now it is getting strong mechanical compression. When the fragment is vascularized, it is soft, it can give only pain or the chemical radiculitis. When the fragment is vascularized, it becomes tough, cartilaginous type. Now it gives the physical symptoms, and the patient may start with weakness. So start with annulus, then leaks causes inflammation around the root of the DRG. Annulus weakens, which leads to the subsequent herniation through the tear. So our target is to remove the embedded disc fragments in the tear to allow the torn annulus to heal. So our target is to remove this structure which has come out, so that these two ends of the annulus can heal themselves. This is the technical technique of the entry that we draw midline, and because due to the alignment, we have to reach the posterior space where the fragment is located. So these are the line lines which we make to enter the posterior lateral aspect of the annulus. This is the setup. This is the basic setup for the patient. Right, for the right-handed person, it's always better to the patient should be on the right side of the patient. And this is the C-arm monitors. This is the endoscopic trolley, and here are the RNCC colleagues, the technical assistant, and the assistant with these instruments. So this is a case. This, I think, has been today is, I think, 10th day of this procedure. The patient has already followed up. This here you can see, this is, I have placed a case which is not very classical, because very classical you can see there is a big fragment lying in the canal and the other migrated, down migrated. Because this is a classical case of subarticular migrated fragment or far lateral, you can say. Not exactly far lateral, but subarticular. And in the area of the lateral recess, where it is the most painful. So there is an L4, L5 here, and you can see here, If you can. Can see this is the primary line. This is the space on the opposite side, left side here, and this is the primary line. You can see here also. This is the primary line, subvertebral, exactly on the category. There is no space at all here. There is a very small fragment, and the patient is so painful, and it has also started the foot drop. The power has become the 4/5 or 3/5 now. So these are the patients where there is a lateral canal and the fragment has migrated to the lateral canal and it is sitting exactly on the root. You can see the L5 is okay, there is no annular tear or something. The canal is also okay, there is no ligamentum, there is no hypertrophy also. Central canal is also normal. And her age is 65 years of age. So only this fragment which is migrated from here, it has gone migrated outside and it is lying into the right subarticular space of the lateral canal. So this is the first step. You plan your trajectory and then you give local anesthetic agent to anesthetize the trajectory. Most of the procedure still is done in local anesthesia. Only the time when we place the sheath, that is the most painful part or the dilator, then we have to give some analgesic to counter it. Or it always can be managed with IV sedation and IV analgesics. So you can see here the needle placement. This is the needle. After this is the long needle, which is we have landed on the facet. Now we increase the angulation and enter into the canal. This is the dilator which is passed through the guidewire, and you place the dilator, and then you place the sheath, and then you insert your scope. And when you land exactly on the correct plane and the place, the procedure doesn't last for 15-20 minutes. Because the fragment is in front of you and you take out it in toto. And patient is on table immediately removed. You can stop all anesthetic agents or all medications which is being given and the patient gets relief. You can see where the fragment was lying here. Little bit LLS has to be cut to deliver the fragment, and now the fragment was removed from the hole. This is the whole big fragment line, and you can see the sheet, and you can see also the positions in the muscularized fragment. You see the leader, which eventually stops because it is not a regular vessel. It is the extravasation part of the equity space, which has lead to the vascularization of the fragment. So, general indications for transfemoral endoscopy: annular tears with discogenic lumbar pain as determined by the provocative discography, both positive and false negative. All disc herniations and protrusions accessible through the foramen, whether they are contained, extruded, or sequestrated. I would like to say foramen because this case is about the transfemoral endoscopy. If you increase the domain and take it to the intervolunar endoscopy, then all the sequestrating or the central disc or the magnetic disc all can be done with endoscopic procedures. The transfemoral is usually reserved for the unilateral symptoms. Unilateral protrusions, unilateral anomalies, and unilateral symptoms. Extrafemoral lesions, even the fallbacks with foraminal fibrosis, recurring herniation, subarticular lateral venous stenosis, subarticular extrusion was there in the last case. Mild, soft, and tissue, central spinal stenosis, foraminal and extraforaminal stenosis. Because foraminal stenosis, when you do transfemoral endoscopy, when you dilate the foramen, when you place your dilator and sheath, sometimes you have to ream the superior articular facet also to place your sheath in the ideal position. Then automatically the foramen gets dilated and the patient gets relief. Then even the discitis also, you have to place the sheath, give a good wash, then the IV antibiotics also work better. And the facet synovial cyst. These are the all indications where the transfemoral endoscopy can be done. High iliac crest is always detrimental to place your sheath in the correct place. Horizontal because the inclination increases. So in that, you either have to go trans-iliac approach or there is a method by which when you increase the inclination, the L5 facet is hindering in the pathway. So you either move the facet and then you can place the sheath. So it has two things. Number one, it increases the femoral, it is a type of femoral when you remove the facet, and you can place your sheath and line to the exact target also. Extent of herniation, extrusion, sequestration, training and experience of interventionists are vital to the consideration of the patient selection. Coagulopathy, sepsis are always a contraindication for percutaneous procedures. Advantages, it is minimally invasive for non-contained discs. In comparison to traditional posterior surgical approach, it do not disturbs muscle and the facet joint complex, which comprises the posterior spinal column, which later, in case of open surgeries, later leads to the functional disabilities. More scientific, as I told, approach to the foreman, approach to the pain generators is reasonable. More precise, not doing the just debulking laminectomy. It is a targeted approach. It is a targeted segmentectomy. No muscle of the bone cutting, patient is aware, awake, and the local anesthesia can be discharged on the next day or the same very day. And results can be immediately assessed post-surgery, either with SLR or patient itself tells that what amount of relief he can always lift a leg, which is a painful SLR before the procedure. Potential complications are there, of course, because you are in the sensitive zone where the both exiting route and the traversing route are there. So you have to be very well about the structures you see in the scope or through the camera, and identification of the structures is very important. The advantages of the procedure is that because the patient is awake, so in awake patient, even with femoral or intralaminar endoscopy, it is difficult to injure a nerve when the patient is awake. This is a main safety guard to you, but correct identification of the structures is very important before you do the procedure or you remove anything from the foramen. Then the nerve injury bleeding is also very, sometimes it is attached to the, always have to very carefully first use a smaller instrument to loosen the fragments and then take the big instruments to remove the fragments. The scar tissue formation is always there as with any surgery. Transient dysesthesia, it can always be there as in any endoscopic procedures. And it occurs in 5 to 15% of the patients. Cause remain unclear, but probably working near DRGs or small hematoma near the exiting route. And it cannot be avoided. We always, sometimes if the transient dysesthesia or the paresthesia increases, you can always go for the transfemoral steroid after 10 to 15 days of the procedure, as the patient complains it. Thank you, sir. It's actually a very big and exhaustive topic. So in short, the indications, concept of the triangle, concept of the DRG and the canal, lateral canal is important to understand. Any other delegates who want to ask something? किसका? See, if there is not an extrusion, if there is annular tear, and sometimes you see the tear has like grade 3, grade 4 tear, the fragment have already crossed all the thickness of the annulus, but yet it is not outside. Then the patient has the radicular pain, and sometimes the back pain is tremendous. I think then also it is well addressed because hardly 10% of the annulus is remaining, rest of it has been gone. So you can cut that annulus, remove the part which is entangled inside the annulus, and it will lead to natural healing, and therefore the pain relief will be good. हमने अभी तक तो वैसा केस नहीं किया है कि टीयर को जाके उसमें see you give does not the fragment does not come out, so it's always do with the transformal steroid if it resolves, but you have to tell the patient that this is impending pain, very less amount of the annulus tissue is remaining, and if it gets ruptures in the future, the canal the fragment will come out and it will really lead to the intense radicular pain, and then you should be prepared for endoscopy. Then you can proceed always.
Thank you, sir, for your talk. Your perspective and expertise are invaluable, and we appreciate your willingness to share with them us today. Moving to our next segment, which is a panel discussion on low back pain and its management. I would request our moderators, Dr. Anurag Agarwal, sir, and Dr. Sarita Singh, ma'am, Professor, Department of Anesthesiology, KGMU, Lucknow, to kindly begin the session.
विनीत सर को बुला लेते हैं. विनीत को फोन करें. सभी बीच है. मैम कैसे वो करेगा, फिर कैमरा के पीछे करेगा. स्लाइड पे स्लाइड्स. आजा पैनल. ठीक है, ये पैनल. हाँ मैदान में बढ़ा. ठीक. सो मैं कर देता हूँ. वो सबको मैं जानते हूँ, नाम खाली. ये कैसे ये कैसे उनको सर आ जाइए, स्टार्ट हो रहा है. So I thank all the speakers and delegates, and with the permission of Professor R.K. Tripathi sir, who is the chairperson, we proceed for the panel discussion. And I would say I am very thankful for my co-moderator, Professor Sarita Singh, who been very busy. She has covered program, and thankful to who is the head of the department of neurosurgery, who is also joining us as the head of department of neurology, Professor LOHIA sir, who is my senior also from my MBBS college. So thank you for coming on this in the occasion. So Department of Physical Medicine and Rehabilitation. Professor Ritu Karoli, ma'am. Ma'am, thank you very much. Ma'am, please आप आगे तो बैठिए ना. So, ma'am is a professor in the Department of General Medicine. Professor Vineet Kumar, he is just coming, joining us. And Dr. Siddharth Verma, my very dear friend, who has come from Mumbai. He is a known famous spine physician in Mumbai, and he is working at the D.Y. Patil University, Mumbai. So we are going to have, I hope, exciting panel discussion. I would like to start to put things in perspective. There are small data. So you have been hearing about the prevalence. Sir, please.
Good afternoon. Good afternoon to all respected dignitaries and dear friends. I'm very thankful to Dr. the organizing secretary of the CME who has invited me for this panel discussion. I hope you will be satisfied with this panel discussion and you will solve all your problems related with the low back pain. Thank you.
So, just to put the things in perspective, why it is important to discuss the chronic low back pain and chronic pain itself. The reason being is that the huge population of the world is suffering from chronic pain. This is the data from the CDC of America, who has said that 1 in 5 Americans are experiencing chronic pain in their life. More than 60 million total number. Same is the data in India. So that means 11 to 40% prevalence and incidence of chronic pain in the entire world. And the maximum part of these patients who are suffering from chronic pain are from low back pain. Second comes the headache, neck pain, facial pain, and you will be surprised to know that the incidence and prevalence of chronic pain is more together combined of cardiac disease, cancer, renal disease all together. So, which are actually have the focus, but low back pain should also have the focus. So, this is the unfortunate finding again, women suffer more than the male counterpart from the chronic pain as well as the low back pain of other kind. So this is a huge socio-economic burden. So this is the American data. Up to $344 billion are being spent on the treatment of chronic pain, especially the low back pain in America. Same is the story in India. More than 85% patients of chronic pain, again, majority of them are suffering from chronic low back pain, are depressed. So this is also a matter of concern because many of us think that the pain is sometimes because of depression. When we are unable to reach a consensus diagnosis, we say pain is because of depression. But now the new consensus is largely that depression is because of chronic pain. So we treat the pain, depression goes away. So this is a very important study I would like to mention here. Here, this study has been sponsored by the government of India, International Center of Population Studies in Mumbai, and we have taken sample size of all the country, all the states, and with multiple location. It has been published last year only in the Pain Journal, which is an International Association of Study of Pain official journal. And here you can see this first graph is showing the incidence prevalence of pain, and the darker the color pain. So you can see that different states are having, our state is having mid of it, and most pain is there in Odisha. And same is that this is for the treatment graph. So to start with the discussion, Ritu Karoli ma'am, these are just the numbers. We would like to ask your experience about you are having a use OPD of the number, and you can tell after in sitting only. What has been your experience? How many patients do you see in your day-to-day practice of low back pain, and what are their conditions? Please share your experience. माइक ऑन करो फोटो भी लेंगे
So this is very rightly pointed that around 30 to 40% of our total patients, if we see an figure, that how many patients are seen to on a particular day. So it is patients, they come and most of the site is backache. So but it is about 50% in females. So that is also correct that female is affected with this low backache.
Ma'am, do you find any particular reason for more women suffering from this back pain?
I think so. One of the factor may be because they are more obese, or they might also have some hypervitaminosis or calcium deficiency.
Okay.
Then
Nutrition deficiency is yes. Sir, would you like to add something, sir? Go ahead, sir.
I would just add that in women, they're mostly and physical activity is confined to household work only.
Sir.
So most cases their trunk musculature is not as strong as in the male gender working outside also.
So basically, we are concerned about the nutrition and exercise to make.
And of course, the postural care during the household activity has to be also taken care of.
Very, very true, very important. Dr. Nikhil Singh sir, आपका कुछ इस बारे में? Because first the patient always goes for a physician. Nobody wants any needles or a knife. So this is the reason I'm asking you.
In neurology OPD, number percentage if we say then it will be more than 60%, including headache, neck pain and back pain. So pain percentage, if we say then it will be more than 60%.
Okay.
And other components, nerve disorder, muscle disorder, seizures, and all those will be within 40%.
Great.
So pain definitely it's very common and it's very challenging. Most of the patients will be having insufficient relief, especially in cases of back pain and neck pain. And etiologically, we see then multiple factors. Most of the time, what I find is lifestyle problem. Is sometimes there will be unaccustomed heavyweight lifting, jerk. This is in case of back pain, this is most common. In case of headache, migraine and tension type headache, in migraine definitely there is a female preponderance, and that is having very common hormonal profile. Etiology that precipitates fasting, and definitely in at least in India, people are negligent over self-care in the routine, especially in the village area. This is a fact. May not be proven in the trial, randomized trial, but this is fact that they do not care as much as they need to be taken.
True, sir, true. So, Siddharth, I would like to this. So, what is the most common diagnosis? What is the percentage of patients who are getting of low back pain? Like you are treating all kinds of chronic pain syndromes, including cancer pain, low back pain, all.
Yeah, so most of the patients in my practice, they are having spine pain, and maybe around say 70% of them are low back pain.
Okay.
So like if I get on an average so 60 patients a day, so out of that I will see maybe 30 to 35 patients of spine pain.
Spine pain. Dr. Deepak, please.
I think so, that is summed up by Dr. A.K. Singh sir. So 50 to 60% patients in, I think every physician OPD, came with either headache or backache. And most of time, the causes, you cannot find a, organic cause in most of the cases.
Okay.
So in women, mostly I feel it's because of psychological problems and hormonal issues. Osteoporosis is obviously more common.
Yes. Waiting to hear that word. That's one of major reasons.
So that are the few causes, but most of time on investigation, we won't find, any organic cause. And I have seen in my practice that they don't respond even to, pain medications also. And you have to resort to some sort of, antidepressants and things like that to respond. So yes, these are the causes.
Okay. What are the most common surgical indication patients you get?
In our practice, I mean, it's already been presented like, osteoporotic fractures undiagnosed before. In younger women, it is mostly the annular tears. I mean, the degenerative pathologies and some subset like 10 to 15% of them with clear neurological findings, they came to us with, extruded disc
Absolute candidate for the surgeries.
and degenerative anesthesis.
Yes. So now after this discussion, we come to few cases we have prepared. Few case scenarios actually. So they are the real patients which came to us. She was only 24-year-old female, delivered a baby 1 month back. And since then, she is bedridden because of severe low back pain. So, sir, the question will be to Dr. केशव साहब कि असल ऐसे मरीज आते हैं कभी कभी जो सीवियर बैक पेन है, कुछ एक्सियल बैक पेन है आफ्टर प्रेगनेंसी है, ड्यूरिंग प्रेगनेंसी. तो सर व्हाट हाउ वुड यू लाइक टू गो फॉर this kind of patient? What is a common practice to deal with these kind of patients? Because they are in acute pain or otherwise healthy. So, sir,
Case of severe back pain and acute onset if there is no focal neurological deficit, no sensory loss, no motor weakness.
sir,
Then first thing we advise few hours or few days, 2-3 days bed rest.
certainly.
NMJ6, this is the common practice. If patient is having significant sleep problem, then we may prescribe amitriptyline. Usually 5 to 7 days, 10 days routine NMJ6 I used to prescribe, and definitely if after purchase and after delivery, then nutritional causes that must be looked. And if pain increases during night, then most of the time I prefer for some imaging, although that is restricted during acute phase, may be avoided if there is no neurological deficit. But if any pain which worsens during night, then I prefer early imaging. May not be within 5 days, 7 days, but within 2 weeks, 2 weeks, 3 weeks, I prefer imaging.
Okay. Sir, as a pain physician, would you like to make some different thought process perhaps? My thought is better.
After delivery, most of the chronic pain is usually a muscular pain because due to the changes in pregnancy, sedentary period which have gone, and increased requirement of calcium which has gone through, and there is always a deficiency of calcium.
Our pain medicine, we try to find out the pain generator.
So proceed sacroiliitis is common.
Yes, yes.
Another thing, toxidemia is common.
Yes, yes.
After
Actually, the diagnosis of sacroiliitis,
extremely, you have to be careful. Within 6 months of delivery, the patient is coming in. History of similar during the pregnancy also. You receive the history of before pregnancy.
Yes, yes.
After that, if the similar type of complaint or related to it, she had been suffering before the pregnancy. So that might have aggravated because to diagnosis increased degeneration and increased the requirement of everything as it goes now.
So it's thank you. This case has already been discussed. Sir, इसमें 89-year-old lady, acute no medical signs symptom, fortunately. Multiple collapse and multiple P score is -4.9, multiple comorbidities. So, if you get this kind of patient, what would you like to?
Because this is a very common scenario.
So this is a common scenario. So as a physician, we would like to
then of course, we will refer this patient for some surgical intervention.
So I will just directly come to Dr. Deepak. इसमें बताऊं कि because of considered case, so this is acute, and so I prefer to put her on conservative management first.
Okay. I will just introduce it.
For neurosurgery, the cutoff has been between books of 4 weeks.
Yes.
Okay, so we'll wait for 4 weeks with osteoporosis treatment and painkillers. And maybe I mean, guarded bed rest also. And after 4 weeks, if still pain persists, and if it hampers her, daily routine life, I will definitely go for some sort of procedure.
Like, अच्छा, अब यहाँ पे मैं पूछूंगा. Would you like to fix her like sensation?
I mean, she doesn't have any deficit. So maybe like whatever plastic or kyphoplasty best way for this question.
Okay, अब इसमें थोड़ा सा मेरा क्वेश्चन सेकंड लिखा हुआ है. What is the consensus of house for long conservative care? Because it has again been written in the books that the prolonged is the progress, most severe is the osteoporosis. She is already minus 4.9 and she is unable to walk because of her pain और उसका न्यूरोलॉजिकल वीकनेस भी आ सकता है. तो सर गुड़िया सर, अब आपका क्या इसमें लगता है कि कंजर्वेटिव केयर इज गोइंग टू हेल्प, और उसमें सबसे इम्पोर्टेंट फैक्टर एब्सोल्यूट बेड रेस्ट.
Yeah, that is a very pertinent question at this juncture. We need to mobilize the patient as well as taking care of the underlying pathology.
Sir.
So, once the anti-osteoporotic treatment is started, we need to monitor clinically as well as by investigation that is indicated. We start mobilizing the patient. But by mobilizing then giving the confines of the room,
It's difficult only.
Yeah, but that's why I'm saying that once the anti-osteoporotic treatment is starting, so we need to assess it clinically. So clinically, it's the extent of pain with or without anesthesia. So the pain and the maximum movement that is possible that should be moved. Is side of pathology. Yes. Initially, we can give some bracing also to protect the fracture side. Of course, long-term bracing is to be avoided because it gives pain and also gives chance for wasting for muscles, but we don't want.
Sir.
So whatever we need to strengthen the muscles, especially so mobilization is must. So we cannot keep the patient in the bed for a long time.
Okay, thank you, sir. Unfortunately, Dr. Dilip is not here. He is in the recent profile meeting. Dr. Deepak, most daughter not पूछना चाहता हूँ. We only like to fix any bone fracture as soon as possible. If it is a femur fracture, is a humerus fracture. So why it is our resolution? Is it justified to wait 4 weeks conservative care for a spine fracture?
See, most of the spine osteoporotic, we are talking about not the traumatic fracture. We are talking about the osteoporotic fractures. Many times you have also seen the patient comes to you and you get an X-ray and you got like a 15 years old osteoporotic fractures, 10 years old osteoporotic fractures. The important thing is healing. It's not about intervening. Okay, so if it is healing, there are standard common guidelines. I mean, when you have to go for vertebroplasty, when you have to go for kyphoplasty, when you have to take care, go for the bed rest only. So it is written if it's not more than 50%, you can wait. Okay, and if it is more than 50%, maybe you require sort of vertebral or kypho. But 4 weeks time should be given. You said why to wait. responding to the pain medications.
No, unfortunately, not.
So if she's not responding to the pain medications, maybe we could try to have something more. Okay, she's not responding to the rest. Actually, I've seen the practice that when we start in treatment, patient response immediately, when the free time only. So it's additions and sort of intervention, I mean, arthroplasty or vertebroplasty in acute setup. It's also a controversial thing. It's a controversial because the patient causes, you know, there are chances of inside the canal. So you want to give from the osteoarthritis to heal, and you want to intervene, that will be far better for us also, and easier for patient also. So she might take a call after like 4 weeks. If she is not responding, then you can go. But if that's not in my practice, maybe it's a controversial thing. It's a lot of discussion.
Sure. But so the start osteoporotic and osteoporotic treatment as soon as possible. Keep bracing, start the movement gradually and protected movement. And if not responding, then you go for intervention.
And see, one good thing in her MRI is that you can see like a white. Yeah. So it's very, I mean, less chance that she will respond to a conservative measurement. So you then need to past and future. So these are few parameters that you have to do. Yes, if the patient comes to intervention, in this scenario, it's also very difficult.
Yeah.
So you say, okay, patient side is also important. Okay.
Thank you. Very good. जी मैम.
Obviously, if neurological deficit is there, then you have to do contraceptive.
Yeah.
That is it.
वो तो फिर ओपन करना ही है उनको, फिक्सेशन करने. This is what we did actually. Bipedicular approach for doing the vertebroplasty because she has already undertaken the conservative care and bed rest for more than, I believe, 1 and 2 months. And you can see that this is the class which we can remove the video of you. So it was not like you to, as Dr. Deepak rightly said, wonderfully responded. Another case, this is a 56-year-old male, low back pain since 1 year. Pain is axial, no radiation, no slight rapid pain to the thighs. Pain increases on standing from sitting posture or turning in bed. करवट लेना मुश्किल है, बैठना मुश्किल है. And XMRI non-specific finding of degeneration and all over the lumbosacral spine was present. So, Karoli ma'am, again आपसे पूछ रहा हूँ, non-specific back pain, इसको commonly mechanical back pain भी बोलते हैं, पहले बोलते थे. What is the percentage of patients you are looking for this kind of patient?
So this is the commonest variety that which we come across, and the usual management strategy as far as we are concerned. So we tramadol, and of course tricyclic antidepressants, SSRIs. But most of the time, actually, they are already from those treatments. So they are not very much satisfied with that treatment, and so for those patients to exercises and to PMR.
On this point, I would like to have your opinion.
Already said most common scenario in PMR practice, 80% of our patients with chronic pain, as all the speakers have pointed out, majority is spine pain. And in such cases, for especially revisions, I would take a few minutes extra. That Dr. Shivani had depicted a very beautiful step pattern of management in one of her slides. The first was diagnosis. So we need to very thoroughly make a proper diagnosis, and most of these such cases fall into postural treatment. And in such cases, in addition to that, we need to identify effects also. So that is mostly related to socio-occupational status, psychological status. Sure. We have to take care of them. The first thing, the second thing she had the repeated ones, cognitive. Okay. So, but they can do all the steps ever very good. So, मैं बहुत से applications को लिया तो 4 से 5 करना है आपको. So, once you take care of the posture and strengthening of the trunk muscles, Dr. Nagi and so once our muscles are strong enough to gain proper support closer to the spine, we want the external bracing that promotes resting.
True, sir.
So once the muscles are strong enough and we are taking care of our children, such cases will be reduced or relieved.
Sure.
Even with interventions, before the intervention, we need to take some question because
डॉक्टर एके सिंह सर आपको भी ऐसे बहुत सारे पेशेंट्स मिलते होंगे इनके लिए व्हाट डू यू थिंक व्हिच कैन बी डन लाइक सर ने बताया मसल अच्छा करना ही है मैम ने बताया अच्छा एनालिसिस देना ही है बट पेशेंट इज नॉट रिस्पॉन्डिंग पेशेंट इज इन टून तो जब तक वो हम डील नहीं कर पा रहे बिकॉज ऑफ दैट तो व्हाट कैन बी दैट थिंग यू कैन थिंक ऑफ
मैं जो प्रैक्टिस में करता हूँ उसमें 3 चीजें हैं
सर
एक तो न्यूट्रिशनल दूसरा पीएमआर सपोर्ट तीसरा पॉलीफार्मेसी में मुझे गाबापेंटिन और डुलॉक्सिटिन
जी
ये दोनों कॉम्बिनेशन से बेस्ट रिजल्ट मिलते हैं
ओके
लेकिन डुलॉक्सिटिन के साथ एटलीस्ट 10% पेशेंट में पुअर टॉलरेंस होता है जिसमें डायरिया और पाल्पिटेशन मैंने सेरोटोनिन सिंड्रोम के माइल्ड फीचर मिलने लगते हैं जिससे प्राय विड्रॉल करना पड़ता है दवा अगर गलती से भी लीक होती तो प्राय वो फीचर आ जाते हैं सेरोटोनिन सिंड्रोम के माइल्ड वैरायटी तो ट्रेमाडोल तो मैं नहीं प्रेफर करता हूँ डुलॉक्सिटिन गाबापेंटिन इसके साथ में एच्यूट मसल रिलैक्सेंट के साथ में यूनिसाइडी
ओके
पेशेंट काफी परसेंटेज में मोर देन 60% पेशेंट रिस्पॉन्ड करते हैं प्रॉब्लम के लिए है कि विड्रॉ करने के बाद पुनः रिकरेंस हो जाता है तो क्रोनिक ये मेडिकेशन यूज से फिर उसका सेकेंडरी जो एडवर्स इफेक्ट है वो
this is for this patient like because we physicians we like to again to find the generator what is the diagnosis why pain is being there
most likely ऐसे केसेस में जहाँ पर रेडिएशन है वहाँ पे उसका जॉइंट का उसके कारण ही रहता है
what is your feeling like what is the best course for treatment for this kind of patient where there is no neurological involvement but that pain is there and as sir rightly said it could be facet joint arthropathy. I think these patients can be sent very early to a pain physician for a diagnostic procedure because we have easily got the diagnostic procedure. So अगर पहले से diagnostic procedure हमारे पास तो अब 56 year में CEO of the company what kind of patients I get this. So he wants a relief and he wants a diagnosis also. So we in fact say this diagnosis and we tell us we have a good facility section over. Okay. So we have procedure. So I have ultrasound in my OPD. So I will do the diagnostic procedure. The patient will say yes, relief yes or no. So I will think that rather than subjecting him to a longer, maybe pharmacotherapy, definitely the patient is also the patient will become injection. So it's quite guided by particular patient and you can treat it immediately. Okay.
So thank you. So I think this is we did the Fawcett Jones syndrome. We did the diagnostic MIPSI first, that is median branch intervention, where we put a little amount of local anesthesia on the median branch, and then immediately ask the patient whether he is or she is getting relief or not. They are usually able to tolerate within 5 minutes of anesthetic. And after that, if the patient is positive and having more than 50% relief, we usually do the radio frequency of the middle branch, which usually works very well and many times gives the patient freedom from the medicines. Dr. Deepak, this is a very curious case scenario. Usually, young call center worker with low back pain, axial back pain, sitting intolerance. Does not बैठ नहीं पाता साहब और बैठने की ड्यूटी है 12 घंटे की कॉल सेंटर में काम करता हूँ एंड मैंने करी सर लोहिया सर आपने देखा होगा, बहुत सुंदर सुंदर बैंक आजकल आ गई है और वो जैसे ताज पहन रखा है वैसे वो कमर पे लपेट कर बाइक पर बिल्कुल चल रहा होता है बेचारा क्योंकि कभी उसको बता दिया कि बाइक करने से आराम आएगा. So there is a broad base this bulge with a small posterior lateral size of about L4-5 level. भाई इसके बारे में बताओ डॉक्टर दीपक कि कैसा how do you usually go about it and how can you reach a consensus what is the best treatment option for this patient?
So in India, we don't, operate for axial pain, neurosurgeons especially.
Yeah.
But in Western world, we used to fuse for the axial pain also. Maybe it can be done by, minimal invasive technique, maybe, open technique. It is a matter of, discussion. But I just will quote, from one of my senior, famous neurosurgeon. He said in one of the conferences, if you don't find an operative organic cause, it's better to refer the patient because they keep on coming to you and they keep on changing the physicians and everyone. But it's very difficult to,
Actually, I have read it. I haven't been to America, what has been. So,
but for axial pain in Western world, they use to fuse.
communication for
It's very difficult to, because there are a lot of opinion in the market also.
yes, yes.
And so they keep on changing and people will say,
replacement or something like that.
for lumbar spine, obviously for cervical spine, we had done few cases.
Yeah.
For lumbar spine, yes, it's in very Western world, but we have not done it yet.
Okay. Sorry, sir, please.
Diagnosis should be thorough.
Sir.
And Dr. Amit also pointed out that we are not going to treat the person.
True, sir.
So, first of all, it is to be ascertain that what is shown on MRI is really complicated.
Sir.
Only then
True, sir.
when I was looking at the names, we had done a case
Sir.
in which the indication of surgery was very much there.
Okay.
But they could not get the surgery done because of one of the other factors like fear or some can be support. And we kept non-surgical rehabilitation treatment and they become better. Even we can also say with surgery or without surgery at 1 year, the clinical status is almost same. So, increased. So we are treating more primarily. So I agree. I'm not saying that. There is a lot of confusion there about the diagnosis, about the management. Shown by some of the speakers,
Sir.
we were showing multiple,
Sir.
and definitely all the
Yes.
so some people at some specific
There was on the patient was going to axial back pain with some intolerance.
after intervention, we lasting relief, but not the permanent relief.
So nothing.
Comes only
True, sir. True. Thank you, sir. So in that patient, what we did like the patient was suffering from 2 years and unfortunately not responding either to the physical rehabilitation or the pain medications or the belt. So we first did the provocative discography to ascertain whether that disc is painful, and then we did the biapioplasty with a cool radio frequency machine. So we did it last year. Patient after very proper rehab for 2 months, patient is better and off medications. So this is another case, but again, this is like to this PID the sign symptom 1 month has been passed. There is no consensus that 4 weeks, 6 weeks or कितना wait करना चाहिए. Like there is a paracental foraminal disc herniation. So again, Dr. Deepak, मैं आपसे पूछूंगा कि how long should wait for the conservative care, or if you go for operation, should the percutaneous spinal endoscopy be given a chance before going for invasive?
No, it doesn't require invasive by any standard. By neurosurgical standards, or I mean any standard, percutaneous spine surgeries are being performed, by a lot of neurosurgeons also.
Sure. Yes.
So you can go. I mean, one of the talks of Dr. Devendra, he showed a different case, a transforaminal and laminectomy. No one does a laminectomy for a transforaminal disc or foraminal disc. So introduction was actually different and the talk was different. So in this case, even if you go for sort of posterior approach, you require a sort of interlaminar approach, and you just cut lamina. Level is remained, and you can easily remove this. And you have to what you said from percutaneous approach, level of expertise. You can go from there, you can go. How long was that? It's already 1 month.
Yeah.
So I need to go for surgery.
Yeah. Okay. So we actually did the same thing. We did this is not the same patient. We did the endoscopy and removed it. अभी ये वाला पेशेंट है सर गोगे सर और मैम आपके पास ऐसे पेशेंट आते होंगे डॉक्टर मैम को तो बहुत आते होंगे ऐसे पेशेंट दिस इज द पेशेंट हु इज अंडर मल्टीपल माइलोमा पेशेंट मल्टीपल कोलैप्सेस होल स्पाइन इन्वॉल्व्ड and active chemotherapy radiotherapy has reached its limit and patient is having severe pain and you can see that the whole spine is there, multiple collapses are there and we found these three area is very painful. So sir, how do कुछ उसमें क्या आप और कर सकते हैं करोली मैम? Plan of
actually, as early as multiple myeloma, and osteoporosis is already started.
Yes. Sir.
So, I think that LOHIA sir will help.
Actually, bad patient. Actually, keep them in bed also need them at the same time, sir. So that explained earlier also, we need to first give some pain relief and start moving the bed. Sir, pointed out sir, pain and osteoporosis and especially for multiple myeloma is already on. Doctor, something?
But I don't know whether any contraindication in this case is there or no, because if there is a thecal side compression and
No, there is no physical compression, no thecal set compression. Patient has neurological intact.
only severe back pain.
Severe back pain, increasing on. And what Dr. Deepak to fix these kind of patients? Can we fix the 3 segment?
I mean, there is one statement that it increases in night and
Yes.
also night posture.
Yes.
So
It's a bit difficult, but you have clearly written that there is extensive tenderness.
Yes,
There is tenderness, and I'll go for intervention in this patient.
Yeah.
Maybe I will go for the tender. I will look for the tender points, and I will inject the cement.
Yes.
And along with that, I will go radiation also.
Sure.
So radiation and the cement will take care of our pain, I think.
Yes. This is what actually we did. We did 3 level vertoplasty.
Radiotherapy also.
And unfortunately, the limit has been reached.
Okay.
Okay. Obviously.
The only problem is you cannot give, I mean, more volume in this case is 20 to 25 ml. That is maximum amount of cement that you can give in a single setting. Otherwise, the chances of the fat leak from the vertebrae. So maybe we require 2 or 3 sessions.
Yes. This kind of patient with another patient of this kind, multiple myeloma only, and he responded. Unfortunately, we could not inject all these levels which were involved. The whole spine was executively punctured. So what we actually did, because patient had the economical viability, so we put our intrathecal morphine pump. And currently he is on 0.4 milligram of morphine only in entire 24 hours, which was not settled on around 120 milligram oral morphine earlier. So this is also. So thank you for a lot of inputs, and sir, Dr. Siddharth, Dr. Vikasam, Dr. Deepak, Dr. Devi, Dr. Kas, please say something, anything, whatever, say 2 words. And then I will put one of my proposal, which I have just in the night.
I just want to put an interesting fact before the audience.
Yeah.
I mean, 2-3 days before I was, reading the literature regarding what is happening, in the back pain. And I came up with a very interesting fact of one senior colleague is working on neuroplasticity.
Okay.
He has written maybe in the near future, in coming few decades, deep brain stimulation and spinal stimulation will become the only treatment modality for the chronic back pains.
True.
Sure.
You
want to add something? So, yes, the only thing while dealing with backache, I think the most neglected part is the inflammatory disorders, which usually get missed both in the clinical examination as well as in the physical reports.
True.
See, we talk about so the one thing at the time when it was in the morning or winters, or especially in the female patients. So inflammatory disorder should be considered before these axial pains.
Sure.
So that is one of the most neglected part which I've seen.
Cool.
So that is the other than that, all these things, yes, they are definitely the future. And then giving pharmacotherapy for a localized pain is not justified, and which is localized is better.
It's better. Thanks. Siddharth, you were saying something. So regarding Sir's observation, actually, I had the fortune of visiting a few of the developing countries to actually see and perform these stimulation procedures. So unfortunately, it did not take up very well in India because of the cost, and also because probably the positioning is not proper. But the same positioning, same condition was there with DBS few years back. Now DBS has taken up very well. So I think that in the future, the SCS is going to be one of the doing this thing. Second thing is in US they are implanting similar to bridging backs. Yes. So now they are focusing more on neuroplasticity rather than focusing on the structural abnormalities. Because as Sir has mentioned, many times in spite of a very bad MRI, the patient is absolutely fine. Yes. Sometimes it is better. So one of the things is MRI is a static image. Yes. And the patient is always the second entry positions can be there. But in most situations, neuroplasticity can solve the problem. Sure. So, as Sir mentioned, this is a very developing field. Yes. So, should also look at this, and we should keep this at the back of our mind and invest in learning this as well.
Sure. Dr. A.K. Singh? I would like to more, I will believe more on preventive aspect. Great. So care must be taken from the childhood to prevent this type of spine at 40 at 50. So the PMR role is more important. Physiotherapy and balance exercise, postural, these things should be inculcated even in during the childhood. So we should not reach 30%, 40% OPD for this type of pain.
Yes.
That will be, I think, more important. But if this happens, then definitely I think multidisciplinary approach is required in these cases.
इसीलिए योगा डे मना रहे हैं.
वैसे तो उसमें कोई दो है
Karoli ma'am.
So what I have learned that we should not stop at the this polytherapy, and we should also, because as the this polytherapy actually contribute to depression and other psychological factors of the patient. So we start treating the depression next.
Yes.
After treating pain. So I think that we should for the specials for this.
Thank you, sir. Go to sir, please.
Ma'am, just a moment, ma'am, we have to say a few words about the osteoporosis, which we believe that is a silent killer.
Factor actually not only for postmenopausal but
Yes, ma'am.
so we should
So, ma'am, is there any, should there any like screening for this thing? Because many times we only get to know about osteoporosis once there is a hip fracture, spine fracture, or other fracture.
there are recommendations for screening also in the postmenopausal females.
Yes, ma'am. Sir, please.
Actually, what Dr. A.K. Singh said, I completely agree. There is rehabilitation.
Sir.
In addition to rehabilitation, so rehabilitation, what Dr. A.K. Singh said that only preventive aspect, and we should carry them young from childhood only. Like in the first case, the postpartum pain.
Sir, sir.
And antenatal rehabilitation, so we can say rehabilitation, so we can prepare to carry the child to handle or saving whatever has to be done. So that postpartum period mostly uneventful as far as musculoskeletal problems are concerned. So that is the mainstay, and we should intervene at the school level.
Thank you, sir. Dr. Nathan, would you like to say something?
I lost the reference, which
Just about the CME, this effort of having a consensus about the conditions and the treatment option available. I think
stress is joined. No patient should suffer unnecessarily with pain.
Yeah.
And whatever modalities we have, whether surgical or rehabilitative or medicine or patient should get early relief. If the facility is there for minimum basic procedure, then we should, because when it comes to especially tertiary care center like this or any other tertiary care center, where the facilities are available for minimum basic procedures, and patient has gone through the months or years from the district to coming to this place and then getting the facility, we should get the correct reference and the most possible the shortest route by which he can get relief.
Thank you. Thank you. In the last day, I thank all the esteemed panelists for taking the, sir. Sir, want to say something, please.
The other thing that we should be striving for, instead of more compartmentalization, we should be going with the team approach.
Certainly.
Like in medicine, so if a patient comes to us, and the patient should get expertise from all the departments, and we should strive to some procedures and SOPs so that patient gets the benefits of all the extra.
सर so on that line अब एक दिमाग में डॉक्टर एके सिंह डॉक्टर दीपक एक आइडिया जस्ट आया था अभी कि जैसे ट्यूमर बोर्ड होता है अपने इंस्टीट्यूट में ऑल द oncology related services they meet once or twice or 2 weekly meeting for difficult cases. We also have we all have different cases which we are unable to make a diagnosis, reach a consensus. So can we have a spine board test? Deepak, what is saying? But this is just an idea I got in my mind. Where we have to set,
Yes, in principle, we can come out with, with some better solution for the complex problems.
yes,
It is always better to discuss and go ahead. It's always better to have knowledge sharing.
इस तरह का अपन लोग कर सकते हैं छोटा सा एक बड़ा अच्छा केस मैंने रखा था अनफॉर्चुनेटली वो मैं यस प्लीज ये वाला जगह देखो भाई हमारा अरे ये बड़ा क्यों नहीं हो रहा अच्छा इसमें देखो दिस पेशेंट केम विद द राइट साइड रेडिकुलोपैथी ऑफ L5 as well as S1 but when we got the MRI so what are the findings so we were unable to do anything not even the transfemoral neuroplasty we could do it. You can, Siddharth, you can see what is the. So there is a disc on the right side. So एक मिनट बस 1 मिनट में खत्म हो रहा है. So सर 1 मिनट बस चाय पी रहे हैं अरे 2 मिनट रुकिए ना अभी आपको वो तो चाहिए तो इसमें जो है अपन इस तरह के केसेस को we can discuss and अगर ये सही भाई इसमें क्या उसमें it could be diagnosed so do you you can see in this second last picture, there's a big target cyst sitting on likely to be an S1 root, as well as there's disc. So these kind of cases we perhaps discuss in the spinal board type of thing. So thank you once again for very patiently for listening and part having the discussion. Thank you, Professor. Karoli ma'am, Dr. Deepak Singh,
यूट्यूब पे दिखा रहा है कि ऑडियो बिट रेट जो है वो हाई है और कह रहे थे 2500 kbps तक लेकर आओ तो क्या
So, एक फोटो ले लिया बस, थोड़ा बोलते हुए चेहरा आना चाहिए ना, थोड़ा दूर से लो ना।